I am Dr. Allison Duggan. I am the Executive Vice President and Chief Operating Officer of Oswego Hospital. I'm also a breast surgeon. And tonight, I would like to say welcome. I see some of my patients here as well. So welcome to our first Ask the Doctor with the General Surgeons. We are, as you can see, missing a general surgeon. And based on what we do, Dr. Reddy is in the operating room with an emergency. And, you know, that is how our lives go. So I'm just going to take some time to familiarize you a little bit with the hospital and or ambulatory surgery unit, and then I'll introduce our docs, and then we'll take some questions. And that seems to be a really good format for going through tonight. On your tables, or if you picked one up when you came in, there are little cards that you can just write a question. If you have it, I'll direct it to a physician, and we'll go through the night that way. Okay? You can start, yes?
Oswego's Health Surgery Center. Our state-of-the-art surgery center provides safe, quality care where our highly trained physicians perform ambulatory, general specialty, minimally invasive and orthopedic surgeries, including total joint. Each year, more than 6,500 surgeries are performed in the surgery center. Among the surgeries performed are general surgery, gastroenterology, orthopedic, OB/GYN, podiatry, pulmonary, urology, ophthalmology, maxillofacial, and dental. Many of our patients go home the same day as their procedure. At Oswego Health, community members can conveniently and safely have their surgery close to home. The Surgery Center enjoys a 90+% patient satisfaction score for the excellent and compassionate care our team of physicians, nurses, and other clinicians provide. Adjacent to the Surgery Center is a comfortable waiting room where loved ones and friends of our patients can wait. We hope you have enjoyed our tour. Our 1,200 employees are dedicated to providing excellent, safe, patient-centered care to the residents of our community.
So we work in that ambulatory surgery unit every day. It's a unit that was built in 2008. We actually have all the advanced equipment that we need. One of the good things about working in a small hospital is the ability to really try to get the equipment as needed per surgeon. And I think we've been able to do that over the last several years. We will find that within the hospital itself, we have excellent hospital-acquired infection rates. So we have the lowest hospital-acquired infection rates in central New York, lower than any of the big hospitals. That includes the surgical site infections that these surgeons here are responsible for. So we have done really well with those quality indicators over the last several years. It speaks to the highness of the quality that we provide just across the river at Oswego Hospital. So I'm going to just introduce my colleagues who are on our panel. You can move on because I introduced myself, so that's me. So I'll start with Dr. Holman. Dr. Holman, who arrived here in 2009 with her husband, Dr. Sokolowski, who's sitting right beside her. Actually, they opened, oh, sorry, Dr. Singh is like on the other side. They opened their practice, Oswego Surgical Associates, at 38 Erie Street in Oswego. Dr. Holman earned her bachelor's degree from Houston Baptist University and then her medical degree from the Medical College of Pennsylvania. She completed a general surgery residency at Metropolitan Hospital in Chicago, and it actually included a year of transplant research, which I did not know about her until I saw this earlier in the month. Dr. Sokolowski, her husband on the other side, now Dr. Singh, earned his bachelor's degree from the University of Missouri in St. Louis. He earned his DO degree from Chicago College of Osteopathic Medicine, and then did his general surgery residency in St. Louis as well. Dr. Singh, just so you know, Dr. Holman does not have two husbands. Dr. Singh, who joined us in July of 2014, joined General Surgery Associates, which is a practice that I'm affiliated with. Dr. Singh did his residency at the Westchester Medical Center at New York Med in Valhalla, in which time he was honored in his role as an excellent teacher to the medical students. He also has just completed a Master of Surgery, and he is a fellow of the American College of Surgeons. Dr. Ruddy, who unfortunately is in the hospital doing surgery and would love to have been here today, is also a general and laparoscopic surgeon like all the other surgeons here, with a special interest in colorectal surgery. So I'm gonna just hand the mic over. I'll start here with Dr. Singh. I'll have him tell us a little bit about some of his interests, what he really likes.
Well, thank you very much for coming over, spending some time and to be here. My name is Jay Singh and Dr. Dagan mentioned. So in terms of interest, I'm a general surgeon, pretty much do all kind of general surgery, like small skin lesions to thyroid, breast, gallbladder, hernia, appendectomy, and it's pretty much pretty much all kind of general surgeries, and as well as I do some advanced hernia surgeries as well. That's pretty much it. So, Dr. Holman.
Okay, we'll pass the mic. General surgeons do a wide breadth of surgery, and I think we can all sit here and pretty much say the same thing for what we do, but we each have kind of special interests. In my particular case, that's breast surgery, but I certainly do all the other surgical procedures that my colleagues do, though I must admit I tend to let some of the harder things, such as those advanced hernia repairs, go to other people as opposed to myself. But we'll hopefully be able to answer any questions that you have.
Yep, I concur. I think we all do pretty much the same type of surgery. General surgery encompasses everything. Probably easier to say what we don't do. We don't do heart surgery, we don't do brain surgery, we don't do spine surgery, we don't do orthopedic surgery. Everything else we pretty much cover. So from a little, bump on the finger, to a hernia or colon resection, we'll be able to take care of all that kind of stuff.
So I have one question so far. Are there any other questions that are written down? Okay. That's okay. I will start making up questions. That's how that will go. So yes, just if you have some questions, hand them off to Jen. I actually have a question. Oh yes, so and I'll make up some questions as I go along as well. So we'll get some questions. So this question, and I will give this question to Dr. Sokolowski. The long-term risk of omeprazole or any of the other PPIs or H2 blockers has been bad in the information sheets. Is it worth the risk to continue to take a PPI or an H2 blocker?
That's a clinical question. You probably asking a question on the wrong form. First thing I would say is, I would recommend that the question be asked to the physician who prescribed you the medication, and maybe have them refer you to a gastroenterologist if that's not the physician who prescribed it to you, so they can give you the risk and benefits. We're general surgeons, we don't directly deal with that on a regular basis. From what I know from the literature that I've read, there has been some suggestions that omeprazole or any other proton pump inhibitor such as pantoprazole, Protonix, or Nexium, or Prevacid, or Acefex, in the long term, potentially has been suggested that it can cause overgrowth of the tissue inside the stomach and potentially cause things like lymphoma and things of that nature. But it has not been proven definitively, and the literature does not agree on that 100%. So as we are treating gastrointestinal conditions of that kind right now, is we do not tell patients that that will happen, and we have patients take omeprazole on a daily basis for as long as they need it, and sometimes they need it for the rest of their life. So that's where the literature is right now. There may be some new literature that I'm not aware of, not being a gastroenterologist, but that's what I know.
So Alan, could I just ask you to follow up on whether or not our surgical procedure that we do for heartburn, talk a little bit about that procedure and discipline of the patient.
Yeah. There's definitely surgical procedure that's been done for heartburn for a long time. Fortunately, omeprazole and pantoprazole and Nexium have been so good at treating heartburn conditions and maintaining them under control. The incident of surgery for that indication has come down quite a bit, and we really don't do them as much anymore. In our facility, not aware, Dr. Singh I don't think does them either. We don't do them because our volume would be so low. We'd have to do maybe 1 or 2 patients a year, and it's better for the patient to go to a center that has a higher volume, like Upstate Medical Center in Syracuse, where they do them on a weekly basis, and the surgeons are very proficient at that. And so what we do, we refer the patient to a high volume surgeon for that procedure. But yes, it can be done.
So I have a question that I'll ask Dr. Holman, and this question is, what is the best way as a patient that I can prepare for surgery?
Well, I think the best way to prepare for surgery is to speak with your surgeon to know what to expect. And I know from my standpoint, that's part of the whole surgical procedure is talking to the patient about why you're doing the surgery you're doing, what exactly is going to happen, and what you expect the outcome to be and the expected post-operative course to be, knowing that things don't always go as planned, but to get a good general idea. And the best way to have that is a discussion with the particular surgeon. At our facility, there's the PAT, or the preoperative testing group, who are also very good at answering questions and helping to navigate through that process in terms of not eating anything after midnight the night before, which medicines are appropriate to take the morning of surgery, best cleansing practices before surgery, that sort of thing.
I think at our hospital, we also have a pre-surgical fact sheet that we hand out from pre-admission testing. And that fact sheet has all the stuff that Dr. Holman just described. It also talks a little bit about some of the things that you may want to do maybe 2 weeks before. Get a little bit of exercise. If you're a smoker, maybe now is a good time to consider quitting, smoke less, walk more, and really be cognizant of what you will need post-operatively as well. So you want to talk to your physician, how long am I going to be out of work? What can I do? What are my restrictions? What are my weight limits? How soon before I can exercise again? It's good to get all of that information, as Dr. Holman said, before surgery, so that you're prepared through the surgery. So now, Dr. Singh, so how long after surgery do I have to stay in the hospital? Well, that is a loaded question, because really it's very different.
It's true, because it all depends what the surgical procedure is. And most of the time nowadays, like a gallbladder surgery or hernia surgery, we patients go home the same day. Appendix surgery, usually patient can go home the same day or maybe the day after. So again, it depends what the surgical procedure is. Something like colon surgery, patient might need to stay in the hospital for a few days, 4 or 5 days, like that. But you know, it all basically depends on the type of surgery. Breast surgery, I would say maybe overnight or so, and they can at the most. Same is for thyroid, you know, overnight they can go home. So it pretty much depends on the type of surgery. If there is any question about a particular surgical type, you know, I can answer that specifically.
Any particular surgery? Did somebody have this question, any particular surgery? Sorry. Oh, go ahead.
Could I ask just a general question?
Sure.
About surgery in the future, robotics. How long in years, you go to a lot of conferences, I'm sure. How many years away are we from robotics taking over even the simplest surgeries?
I think the robotics are already here. You know, it's not in Oswego, but it's there in Syracuse already. When we say smaller surgery, like hernia surgery, if we call that a smaller surgery, I won't call that a smaller surgery though. But people are doing robotic hernia surgery already. So, and I think the fact is, does it really require? There are few surgical procedures where robotics, you know, do come into play, where it is helpful to the patient as well as the team, the surgical team over there. But it's not all the time. It's a lot of money to spend for robots. So for routine, small, so-called small procedures, I don't think the robot, the hospital would buy a robot. But yes, for bigger procedures, yes, the robotics are already here.
So, if we're gonna talk robotics, if you're talking about science fiction currently, where a robot is doing all the surgery and there is not a human being anywhere around, we are not going to be there for a very, very, very long time. But if we take some surgeries like, believe it or not, hysterectomy, pelvic surgeries, where the pelvis is stable, it doesn't really move around, so it's okay, you're outside of the body, that kind of works well, that's already being done. So there's robotics for that. That is, however, manned by a human who is just sitting a little way away from the patient, and then somebody still has to put all the equipment in the patient, so you still have to put all the ports that we would normally use for a laparoscopic surgery, that everybody here on the panel does, which is the difference between robotics and laparoscopic surgery. With robotics, you're sitting away from the patient, and with laparoscopic surgery, you're actually manning the instruments from outside of the patient. So we do a lot of laparoscopic surgeries here in Oswego. Actually, I'm gonna have the panel talk a little bit about that, since I'm without questions right now. So I'm gonna throw in a laparoscopic surgery for everybody, and just kind of have them walk us through how they would go about doing that. So Dr. Singh, I'm gonna ask you to talk about the surgery that Dr. Ruddy is currently doing, which is a laparoscopic appendectomy. So.
Okay, I'm going to talk about the laparoscopic appendectomy, but before that, I'm going to say, you know, for robotic surgery, since we brought that in, the procedure which can be done in half an hour, 45 minutes, to get the robots and everything together is going to take 2 hours. Already we are delaying. Secondly, the surgeon doesn't have the feel of the tissue. So he's sitting over there, but he doesn't having a feel of the tissue. So that's another problem with that. In terms of the procedure which is being done right now, it's laparoscopic, means we're doing without making bigger incision, just making small holes, and using the longer instruments and the camera. First we inflate the abdomen, you know, belly with it's called the gas, and then it's inflated like a balloon, can see the structures a little better, and then basically, get the appendix out through one of the hole. Usually, I use three small incision, 5 millimeter, one slightly bigger, and get the appendix out. With the laparoscopic appendectomy, the pain is less. Patient can return to work faster, as well as can go home. Like if the surgery is done today, if everything is without a problem, patient can go home tomorrow.
So Dr. Singh talked a little bit about laparoscopic appendectomy. I'm going to ask Dr. Holman to talk about laparoscopic cholecystectomy. And as a point of reference, so Dr. Singh said a 5 millimeter port. 5 millimeters is 1/5 of an inch. So that's what we mean, 1/5 of an inch. That's how tiny those incisions are that he's working with. So probably one of the things that we've had in the past, and everybody knows, is that your gallbladder can go pretty bad on you, right? So, get a lot of fat in the diet, get a lot of gallstones, and your gallbladder just decides one day it doesn't like you anymore. And when that happens, usually the pain is tremendous. There's a lot of, I shouldn't say this because we're eating nausea and vomiting, but we're general surgeons, we live nausea and vomiting. And now you need somebody like Dr. Holman to come in and remove your gallbladder. So as a point of reference, in the past, we would remove your gallbladder through a large incision across the right side. You'd be in the hospital for 5 days, and it would just be painful to heal. And anybody here who has an open gallbladder knows exactly what I'm talking about. And so, as a point of reference, now Dr. Holman's going to talk about what we do now.
So the way we do it now is a lot simpler and easier than it used to be, which is a good thing. As Dr. Duggan said, it used to be that big cut right underneath the rib cage there. Now we can do it with 3 or 4 smaller cuts, and exactly how many cuts and what size the cuts are depends on the surgeon's preference, and it also depends on how big that gallbladder is that has to come out, because it has to come out through a hole somewhere. So what we do these days is what Dr. Singh was talking about. We need to be able to see inside the belly, so we're letting that gas go in to inflate it like a balloon. We have to kind of lift the liver up so we can see the gallbladder hiding underneath there, and then start to free it from all of the attachments that it has. Cut the drainage system from the gallbladder, cut the blood supply from the gallbladder, and then remove it from where it's sitting underneath the liver there, so that then we can take it out. And this procedure, as opposed to the old-fashioned one, has the advantage of it's a same-day procedure, 99+% of the time. Because there are smaller cuts, the risk of a hernia afterwards is minimal, so you're able to get back to normal activity a lot quicker. So it's a benefit to the patient to be able to do it this way, and we're able to do it this way the vast majority of the time these days.
So as Dr. Holman gave me the wonderful lead-in to hernias, that I'm going to have Dr. Sokolowski talk a little bit about the repair of hernias laparoscopically. So one of the things with hernias, so a hernia is a break in the lining of the body. So usually that hernia is along the abdominal wall. So people are used to seeing hernias in the groin or at the belly button, which is just a protrusion of the things that are in the abdomen through the abdominal wall. And so, oh, I'm sorry, he just made a face. He just made a face at that. So it's general surgery, so, we kind of live these things and we like them, right? So one of the things that we would do in the past to fix these, we would make big incisions, try to tuck things back in, and then we'll put covering on it and we'll sew it up, and you couldn't move. And I remember before, when I was a resident, the abdominal binder forever, and don't move, don't stand up, don't sit down, don't lay down, don't roll over. And we have come such a long way, so I'm going to have Dr. Sokolowski talk a little bit about how he fixes laparoscope.
Anyone can find it.
Alright, there's multiple types of hernia. Okay, so there's the hernias on the belly wall. You know, belly button hernia, you've seen that, little kids going around with a little poking out belly buttons. Then there's hernias in the groin, there's all kinds of different hernias. As Dr. Duggan said, the easy way to think about a hernia is, you know, if you have a little hole on the elbow or on the jacket, you know, you can do one thing, you can do a couple things to it, right, to fix it. You can take some thread and sew it up the hole, right? Or you can patch it with a patch on the outside, right? Well, that's what we do laparoscopically. We don't sew them with a thread anymore because when you sew the hole and then you pull on it a little bit, it'll start unraveling, right, and start breaking up again. But if you put a patch on it, then there's no tension there. So that repair lasts a lot longer. And what we do is we put a patch on the inside of the belly. So if you can think of a little bit of hole, like in a belly button, for example, instead of closing it together, we'll put a patch on the inside of the belly that covers the inside so that nothing can come through that hole anymore. And basically that's how we do it. We do it through two or three little tiny incision sites with little pencil-sized laparoscopic instruments, and put a patch on the inside, and that's it. And you wake up, and then you go home, and in about 2 or 3 days afterwards, you can do your regular normal activity, your normal life, and not worry about. I mean, we don't want you to go and lift 100 pounds, you know, for a couple of weeks, but within reason. That's how we do it. Oh, Dr. Holman is telling me that I'm missing things. Recurrence rates. She's basically with that type of repair, the chance that the hernia is going to come back is a lot lower because you're not creating any tension by approximating the edges with the thread. You're basically just patching up the hole. The hole's still there. You just put a patch on it, so there's no tension. There's no, you know, you can strain, you can cough, you can do anything you like, and it's not going to break down. There's nothing to break down because there's no tension. So the recurrence rate is a lot lower. So you go from 20% recurrence rate for the regular old-fashioned repair with a thread to about 3 to 4% recurrence rate for laparoscopic hernia repair with the mesh. And everybody's thinking mesh. Oh my goodness, I'm going to die because it's mesh. It's not true. That's not the type of mesh we use. The mesh that is in trouble right now mostly is the mesh that was used in gynecologic procedures, urologic procedures for bladder lifts and things like that. It's a completely different mesh used in a different area of the body. So you don't have to worry about that. At least not yet. You never know what's going to happen on TV next.
I think it's where you put the mesh rather than the mesh itself. That is the problem. We have a question.
I understand that you don't do the heartburn procedures, but can you talk a little bit about what the options might be for those, and you know, what your symptoms would be in order to go that route, and what the options would be for the procedures if there's
Sure.
more than one? Or
Can you hear me without the microphone? Can everybody hear me? No? Okay. Let's use the microphone. Well, you're asking about indications for the operation, okay. So basically, the rule of thumb is, we do the surgery if the medications do not work. If the heartburn is so bad that it's starting to cause a condition that will lead to cancer, and we can't stop it, and it's early enough, then we will do the operation. The operation entails wrapping the stomach around the esophagus, first pulling the esophagus down, so the food pipe. So basically what you have in your body, you know, you swallow something, and it goes through your food pipe, and it gets into your stomach, right? The food pipe is up in your chest, the stomach is down in your belly. So with the heartburn, what happens is that distinction between the chest and the belly is blurred. There is not a good enough barrier between the chest and the belly, and so what happens is the stomach comes up into your chest, and that's where the heartburn happens, because the stomach's in your chest, called a hiatal hernia. I'm sure everybody heard that before. And so the objective of the operation is to pull down the stomach back down into the belly and wrap it around the esophagus, so it creates this bulb thing, so it can't get up into the chest anymore through the weakness that's there. And it's a fairly invasive operation. I mean, just describing it, I'm sure you can understand. So there are side effects of the operation. You know, if you make it too tight, then you can't swallow. Things don't go down because it's tight. If you make it too loose, then it doesn't work. Then the acid reflux still happens. You still have heartburn. So there's all these issues. And so if you're taking, let's say, omeprazole, and you're taking a maximum dose, twice the maximum dose, and it doesn't work, you still have heartburn. Clearly, you need an operation. If you have a condition called Barrett's esophagus, where the lining of the food pipe gets burned out by the acid that keeps coming up there and causes a precancerous state and then can lead to cancer, then and the medications don't make it better, then absolutely you need the operation. But that's nowadays very, very rare. I mean, most of us do upper endoscopies here, and we see Barrett's esophagus all the time, and we see severe heartburn all the time and damage. And I probably, in the 8.5 years that I've been here, I've referred maybe one patient to Syracuse for a fund application for an operation. Everybody else I was able to control with Protonix, pantoprazole, omeprazole.
So you just keep trying the different
Until you find which one works best and you control the dosage. Now, there are some people who don't respond to the medications very well, but as long as they can control their heartburn with diet and they don't develop a precancerous condition, then they don't need the operation.
Thank you.
From the standpoint of a fund application, which is what we call that wrap, to use a better word, there are some GI tests that you could do. There's some tests that can be done by a gastroenterologist to tell you whether or not you have the right pressure there, you're refluxing to the point that you would need this operation. So we tend not to go from our standpoint where we're doing the endoscopy right to you having an operation, as Dr. Sokolovsky states. The reason that this panel doesn't do that procedure, there's just so few of them, that it's best that it's concentrated with somebody who's doing them all the time. And so that's why we would refer. But there are ways to determine whether or not you're a candidate, and there's some studies that you have to do prior to that. You want to see how much you're refluxing, when you're refluxing, what's the pressure there at the esophagus, the food pipe, before it goes into the stomach. Those things will determine whether or not you would be a candidate. And you'd go through the entire workup with a gastroenterologist. So if you're on a medication and you're feeling that you need to move to something else, to really go through and get an assessment by a gastroenterologist would be in your best interest. So I would say that's where you want to go next, and from there they will help you determine whether or not surgery is the right option for you. So that's how that works. So I have another question, and it says, I'm worried about pain after surgery, and can you speak about how you deal with postoperative pain? And this is a loaded question in many ways, because treatment of postoperative pain sometimes will depend on the pain threshold of a patient. But I'm going to ask Dr. Singh to address that one.
That's really a very good question, though. Again, it depends what surgery is being done. When I do like a big colon surgery or advanced big hernia surgery, I actually, my pain control starts before the surgery. They do get medications before the surgery is even done. And what I do, those kind of big procedures, that I actually do what is called epidural catheter. I'm sure you're aware of that. There is a catheter we put in the bag. Sorry. Put the catheter in the bag, and through that we give the pain medications, which usually I keep it for around 48 hours or so. And the reason for that is because the pain after the dissection and the surgery is usually more early on, and obviously it does go down as with the time. So with that, patients have been successful. Patients having zero pain, you ask, you have any pain? They say zero pain. So it all depends. But again, that can cannot be done for smaller cases or patients who go home. But again, for them, we do give medications like, first of all, the numbing medicine that does last for a few hours. And again, after that, the Tylenol, we all know Tylenol or narcotics are given. Try to cut down on the narcotics need as much as we can. And also it depends, as Dr. Duggan said, threshold, as well as whether they can tolerate like something like Motrin or ibuprofen. Yes, the pain has to be controlled because it's important, but that's how we try to control the pain.
I mean, I think Dr. Singh hit most of the major points there. I mean, the most important thing is to tell the patient kind of what to expect, from the particular surgery that you're doing. And everyone has different levels of pain they can tolerate, but everyone also has some basic concepts of what hurts. And so if you're talking to the patient and you're talking about a big surgery such as a colon resection, where you're having to actually cut through the thicker layers of the belly wall, through the muscle, that's going to hurt a lot more than if you're taking a skin lesion off of somebody, a mole, that sort of thing. So you just have to talk to the patient, kind of tell them what to expect and how you're going to help control their pain and minimize how much pain medicine they actually need, because that's in everyone's best interest.
Yeah, I think the big elephant in the room when we talk about post-op pain is the use of narcotics, right? So the idea is that we have some narcotic drugs that have, unfortunately, the side effect of causing some dependence. And whether or not that would happen with short-term use or long-term use is really dependent on the patient. So there are some patients who can't develop a dependence on narcotics with very short term use. But as a society in general, we are trying to decrease the amount of narcotics that we are prescribing. And the reason is, okay, so let's say that you have had a hernia repair and you are fantastic, but as a physician, my standard spiel is to give 60 tabs of whatever narcotics for everybody that comes in. And that's my standard. I do it no matter what. But you've done really, really well, and you've taken 2. So now there are 58 tabs hanging out in your medicine cabinet. Okay, what happens to those medications? So you can dispose of them. People like to flush them down the toilet. Bad, don't do that. Gets into the water, so you don't want to do that. Or you could just leave them there for anybody who comes into your house. And they could just go ahead and grab some Lortab or Dilaudid or whatever and use it. And that's how we have a problem with prescription drugs that are floating through the society, being used by people who did not have surgery. So that's one of the initiatives that we are working on at Oswego Hospital. So we're really trying to decrease our narcotic use throughout the emergency room and the floor. We really want to give patients alternatives: epidural, Tylenol, Motrin, non-narcotic medications. But keep in mind, we don't want anybody to be in pain. So if what you need is a narcotic medication, that's what we're going to give to the patient, if that's what you need for pain management. But we don't want people actually bringing home medications that they're no longer going to use.
Question to the panel regarding mammography. There's controversy at the moment that mammography may be overdiagnosing breast cancer, particularly intraductal cancer. Would you discuss this concern?
That's a great question. First and foremost, there is a lot of controversy about when even to start mammography and how often to perform it. And you can look at 10 different organizations out there, going from the Association of Radiology to breast cancer surgeons to the American Medical Association, American Cancer Society, and everybody's gonna give you a slightly different recommendation as to what to do. And I think where it comes down to is, once again, nothing beats the discussion between you and your physician about what's appropriate for you. Everyone has a general consensus about definitely from age 50 getting a mammogram every year. Some people will say every 2 years. And there's kind of that gray zone from 40 to 50, and this is where the discussion comes in to talk about what a woman's specific risk factors are. The goal of the mammography is obviously to find something bad before it turns into something worse, or to find something precancerous and deal with it so it can't turn into anything worse either. So this is kind of an individualized journey, so to speak, for what to do. And then the concern that we're overdiagnosing them, that is a good question that I think the literature will have to bear out as we tend to do a little bit less. Did we actually help the situation or not? I mean, part of it is also, people don't like to think of having bad cells in their body. That's a scary thought, and that becomes where that discussion about what is going to be of best benefit to each individual woman comes in.
I think in particular to your question of ductal carcinoma in situ. So ductal carcinoma in situ is non-invasive breast cancer, what we would classify as stage 0 breast cancer. It means that it doesn't have the ability to spread outside of the breast at all. It's confined in the breast. So if it is, and it's just DCIS, why would you choose to treat it? I think the question that will pan out is not whether or not we should treat DCIS, but whether or not we should treat it as aggressively as we treat invasive cancer. I think that's the question that's going to be answered. But for DCIS in particular, that non-invasive breast cancer, I think, yes, we have seen an increase in incidence because of the use of mammography in younger and younger people. But the fact that the ductal carcinoma in situ is found now versus an invasive cancer found later, I don't think that changes much. You're correct. Because overall, the treatment of breast cancer has really been elevated to the point that our survival for stage 1 disease, so people with small tumors that haven't spread anywhere, that's really, really high. So whether or not we do have to treat these small tumors is a question that I think is going to be answered in the upcoming years. I think we'll find that, yes, we're still going to treat them, but we'll probably find that we're not going to treat DCIS on the same order that we treat stage 1 breast cancer. I think we'll get to the point where we'll see we should be a little bit more selective about adding radiation to those patients. I think that's where you'll see the literature go. But we do get that question from time to time, whether or not we should treat ductal carcinoma in situ or have it be like lobular carcinoma in situ. And I'm getting technical for Dr. Newbold, but whether or not we should handle it the way we handle lobular carcinoma in situ and use it as a marker rather than as a cancer itself. Because when you say ductal carcinoma in situ and you call it a stage 0 cancer, it really ups the ante for the patient. Because now you're saying I have a cancer and then you're going to tell me you're not going to treat it, that becomes very, very difficult. Oh, I'm sorry, she had a question before you.
Yes, I'd like you to address, I'd like you to address telemedicine,